please.
Thank you, Mr. Chairman. So the topic I'm going to discuss is the role of coronary revascularization in the ICD in survivors of out-of-hospital cardiac arrest. And really, the evidence that I will show you is circumstantial evidence. We have very little hard data in this area, very little. I have a multiple choice question for you, and that is, for those of you visiting the United States, if you decide to have a cardiac arrest while you're there, what 3 places would you choose? And I'll give you the answer. One is Rochester, Minnesota, where I work. The other is an airport. And the third is be in a Las Vegas casino, because then you will be resuscitated. Now, this is the Arrhythmia Triangle, originally developed by the late Philippe Coumel. And he postulated that for a sustained arrhythmia to take place, whether it be ventricular or supraventricular, you need a substrate, modulating factors, and triggers, PVCs or atrial extrasystoles, and PES is programmed electrical stimulation. And in the presence of a suitable substrate, a trigger can induce an arrhythmia, particularly if in a particular autonomic milieu, which is very important. Because this is why one day you can program a ventricle and no arrhythmia, and the next day you go back and there is an arrhythmia. The substrate, typically, in most people with coronary disease, is a mixture of scar and fibrosis, left ventricular hypertrophy, and maybe islands of ischemia. And what I'm going to focus on this morning is the role of ischemia. Because if ischemia is in fact responsible for out-of-hospital cardiac arrest, then anti-ischemic therapy alone, once we resuscitate the patient, anti-ischemic therapy alone should take care of the problem. And that's the critical question. So everything I'm going to discuss is how important is acute ischemia in out-of-hospital cardiac arrest. And there is a considerable amount of evidence that I will go through, both from the epidemiology, pathologic and anatomic, ambulatory monitoring, clinical observations, and I'll take you through this to show you that there is sound evidence to implicate ischemia in sudden cardiac death. What the implications are for therapy are not so clear-cut. Now, to begin with, this is one of the very first early studies of 24 patients with balloon inflation undergoing balloon angioplasty. And shown here is the control, the balloon inflation, and these are the superimposed images. And what you can see is that ischemia prolongs the QT interval. So this is just one piece of evidence that I'm going to go through and show you. And if you look at these 74 patients, baseline balloon inflation, clearly, if you believe that a prolonged QT interval is an arrhythmic mechanism, ischemia prolongs the QT interval. Now, in terms of the risk of sudden death, it's interesting to look at the risk factors that predict sudden cardiac death from the Framingham study. So these are the variables that predict sudden death: age, systolic blood pressure, ECG abnormalities, cholesterol, vital capacity, smoking, relative weight, and heart rate. And these are the deciles of multivariate risk in men and women. And the more of these risk factors you have, the greater the risk of sudden cardiac death. But I could substitute this and just say the risk of cardiac death. And what it shows you is that sudden cardiac death tracks total cardiac death. And therefore, clearly, ischemia plays a role. But it's very general from an epidemiologic perspective. Other data come from the circadian variation that I talked about this morning. This is the circadian variation in myocardial infarction, stroke, ischemia, and sudden cardiac death. And I was talking about it this morning in regard to sleep apnea. And what you can see is the peak of sudden cardiac death is between 6 and 12 a.m., which is also the peak in the incidence of myocardial infarction, stroke, and ischemia, as determined on a Holter monitor. So further evidence that ischemia behaves like the other cardiac risk factors that cause total cardiac death in addition to sudden cardiac death. Now, there's some very interesting data from natural disasters, and this is from the Northridge Park earthquake that occurred in Los Angeles about 20 years ago. And if you look on the day of the earthquake, which was the 17th, this is deaths due to atherosclerotic vascular disease from the coroner's office, and these are on the days before and after the earthquake. So there's an immediate peak in atherosclerotic vascular disease death. But what is interesting is to look at sudden cardiac death. Exactly the same. Exactly the same. Sudden cardiac death tracks total cardiac death, suggesting that there may be a common ischemic etiology. Of interest, actually, in the San Francisco earthquake, they didn't see this. And some of the speculation is that the Northridge Park earthquake occurred very close to 6 a.m. in the morning at the time of that diurnal peak in sudden death, whereas the San Francisco earthquake occurred in the afternoon. But either way, just additional data to suggest that sudden cardiac death tracks all cardiac death, and therefore ischemia should be playing a role. Now, this is interesting data from the 1996 European Football Championship when France defeated Holland. And on the day of the match, the 22nd, you see here a peak in all-cause mortality amongst Dutchmen and an increase in mortality due to MI and stroke and also sudden cardiac death. What is particularly interesting is to look at Dutch women. No difference. So there are several explanations for this. One of them is it's the attitudes of Dutch women. First of all, that they're just not interested in soccer. Maybe they're more philosophical about losing. The other is they couldn't care less about soccer or their husbands' concerns about losing. Didn't matter to them whether their husbands were worried. Or it could be that there are different gender responses to these traumatic events, such as losing in a major championship. And there is some interesting data from an early PTCA study of 205 patients. And if you look at balloon inflation, there's a significant difference between women and men in the way they respond, in that women are much more parasympathetic, with a bradycardia, increased heart rate variability, hypotension, a vagal response, less PVCs, and men have a more sympathetic response. And this may actually play a role in the gender differences in out-of-hospital cardiac arrest in patients with myocardial infarction. And that is that more men are likely to arrest before coming to hospital, and there's good data to support that, whereas women are more likely to survive to hospital. But that may mean that sicker patients survive to hospital, which is one reason why the mortality is higher in women. Now, there's data from coronary angiography. This is from a Spaulding study in Michigan, 84 patients with recent coronary occlusions in 40 type 2 lesions. And this was the extent of disease in these resuscitated cardiac arrest survivors. Normal coronaries, insignificant disease, but the majority of patients who had had a cardiac arrest, an out-of-hospital arrest, had significant 1, 2, and 3 vessel disease, and some with left main. So further evidence, anatomic evidence, that in people who've had an out-of-hospital cardiac arrest, there is an ischemic etiology in a large proportion. And this is an autopsy study from the Armed Forces Institute of Pathology by Dr. Burke. 141 men with severe coronary disease, sudden cardiac death. 82% of the deaths occurred at rest. And this is the pathology, which is quite interesting. Plaque rupture and intraplaque hemorrhage. And with exertion, much higher proportion at plaque rupture and intraplaque hemorrhage. But even in those occurring at rest, a significant number of the deaths were due to the acute lesion of plaque rupture or intraplaque hemorrhage, the lesion that causes myocardial infarction. So very good evidence for that. And then we've all had this unfortunate experience of a patient in a stress test becoming very ischemic, ST depression, and fibrillates. Clear evidence that acute ischemia causes sudden cardiac death. Clear evidence. So to summarize, what I've shown you is actually a little bit that the glass is half empty or half full. I've pointed out that coronary stenoses are significant in these patients. but about 40% or so do not have coronary stenosis. Plaque fissure and thrombus in the study I showed you was present in about 70%, but in about 30% it's not present. The treadmill I demonstrated with signs of ischemia going on to fibrillation. Very impressive. Clear-cut etiology, cause and effect. But many people who've had an out-of-hospital cardiac arrest will have a normal stress test, as shown here. So there is evidence, but it's not complete. Now, the other area we can look for evidence is to look at patients who've been revascularized and had an ICD. And here I think there's some very interesting data to suggest that ischemia is responsible for out-of-hospital cardiac arrest. 16 trials, this is USUS meta-analysis of beta blocker therapy. Overall, a significant reduction in mortality from beta blockers. This is old data from 1985. But what is interesting is to see that the effect of beta blockers was every bit as impressive on sudden cardiac death as it was on non-fatal infarction. Here again, further evidence that sudden death tracks non-sudden death, that they maybe join and have a joint ischemic etiology. And this is from a study that I published with my colleague David Holmes several years ago with the CAS registry. We looked at patients in this registry with heart failure and looked at the effect of surgery and medicine or medical therapy on sudden cardiac death, not total death, but sudden cardiac death. And this makes a point that often isn't made, actually, and that is that the major benefit of surgery versus medical therapy on mortality in the early trials is actually on sudden cardiac death. It's not on myocardial infarction. It's on sudden cardiac death. And in those with 2-vessel disease and 3-vessel disease, you can see a huge benefit from surgery in terms of sudden cardiac death. Whereas in this same registry, we were unable to show much of an effect of surgery on myocardial infarction. What does this suggest? It suggests that in people with LV dysfunction and ischemia, if you correct the ischemia with revascularization, you will reduce the risk of sudden cardiac death. So these are the sources of evidence that I've gone through. I've just given you a little snapshot, but there is considerable epidemiologic, pathologic, angiographic evidence implicating ischemia in sudden cardiac death. We have the data from ambulatory monitoring and stress testing, and then I'll show you some data from invasive electrophysiologic studies. And I've pointed out that pharmacologic and surgical therapies, beta blockers and coronary bypass surgery, both reduce ischemia and they reduce sudden cardiac death. But this is the key question. Anti-ischemic therapy reduces but does not eliminate the risk of sudden cardiac death. We're not treating atrial fibrillation here. We're treating sudden cardiac death. And that's the problem in the clinical dilemma, because I have no doubt that anti-ischemic therapy reduces sudden cardiac death, but does it eliminate it? And here's a study that suggests it doesn't. This is a group of people with atherosclerotic heart disease who had survived a sudden cardiac death, unrelated to acute myocardial infarction. Inducibility varied in these series. But basically, if you summarize the data, about 63% of these patients had inducible sustained monomorphic VT. That means they have a fixed electrical substrate, scar interacting with perhaps ischemia. These patients with polymorphic VT or non-sustained VT may have had an acute ischemic event, but the moment you induce in the electrophysiologic laboratory sustained monomorphic VT, you have a substrate. It's a fixed substrate. Ischemia, when it occurs, and when ischemia causes an arrhythmia, what it does, it causes polymorphic VT or ventricular fibrillation, but not sustained monomorphic VT. And now we come to the relative lack of data. There's very little data. This is a paper from Natali, 58 sudden cardiac death survivors. All of these patients had bypass surgery. They all had an ICD implant, and then they tested them before they went home. So they basically, sudden cardiac death, identified the ischemic disease, corrected it, and then did an EP study before they went home. And this is what's so disappointing. Relatively, of these 40, 50, 60% who had no inducible arrhythmias, they continued to have appropriate shocks. They continued to have appropriate shocks, even though they'd corrected the arrhythmia. And in a number of the others, they were still inducible, even though they had corrected the arrhythmia. Still inducible, sustained monomorphic VT and VF, suggesting that there is in most of these people a fixed substrate. And then one other study from Dr. Emil Daoud from Michigan, only 23 patients, sudden cardiac death survivors. They had unstable angina or ischemia on stress testing before the operation. They were all successfully coronary revascularized. They then did an EP study. They were non-inducible, problem solved, followed them for 3 years, 23 patients, 10 shocks, 10 patients or 43% had appropriate had shocks, and of those, 8 patients had 1 to 22 shocks, and 9 of these 10 patients had syncope or near syncope. So very persuasive evidence that despite eliminating the putative cause of an ischemic sudden cardiac death, these patients continued to experience arrhythmias. So, in terms of the role of anti-ischemic therapy and coronary revascularization in preventing sudden cardiac death, for primary prevention, anti-ischemic therapy is extremely good. I mean, if we get rid of atherosclerosis, we get rid of a large part of sudden death. So there is no evidence and no doubt that reducing risk factors as part of the overall attack on cardiovascular disease will in fact result in a reduction in sudden cardiac death. And we have seen that. As you see coronary heart disease mortality decline around the world, so is there a decline in sudden cardiac death. But when it comes to secondary prevention in the management of the survivors of VT-VF, and we see a lot of these patients now, because, as Dr. Sunday said, the standard of resuscitation is getting very high. In these patients, in my practice, all of them go to angiography. Many of them will be revascularized. But revascularization alone is a rare event. That patient who had ischemia on the treadmill had normal regional wall motion abnormalities at angiography with a thrombus in the LAD. He was revascularized and he did not get an ICD, but that's a rare event in our practice. And I think we've got the data that drugs do not work, that the ICD is superior from the AVID, CASH, and SIDS trials. So what about the patient with an out-of-hospital cardiac arrest and a recent STEMI? The guidelines currently do not advise an ICD. But where's the data? Where are the data? Most of the data come from in the pre-reperfusion era. In terms of, the first 24 hours, it doesn't matter if they fibrillate. After that, it does matter. And it's very difficult to study this issue. I've tried using our own databases, and we haven't been able to really get the answer. So what about the patient that has a cardiac arrest and presents with a myocardial infarction, and the arrest was 1 hour before? Probably that's ischemic. Probably we don't have to worry. But what about if it was STEMI 23 hours old and the patient fibrillates? What is the risk of future events? Very difficult, and we really don't have the data that we need. And I want to close with this question here. What about future ischemic events? Because it's an interesting concept that one person occludes a coronary artery and they have a myocardial infarction. They come in a hospital, we reperfuse them. The other patient has the same plaque rupture, they occlude a coronary artery, but they fibrillate, and they have an out-of-hospital arrest. And there's some really interesting data to suggest there may be a genetic predisposition. And this is, and I'll close with a study from UVA in the Paris prospective study, of about 7,000 men without known ischemic heart disease. And if you look at the parental history of sudden cardiac death, if these individuals had a parental history of sudden cardiac death, this was at least the parental history of sudden cardiac death, 18.6 had sudden death, death due to MI, and all others. Now, how did it affect the children? If the children, if they had these 7,000 patients, if their parents had a history of parental sudden cardiac death, their odds ratio of dying a sudden cardiac death was almost doubled, where there was no significant increase in fatal MI. If both parents died a sudden cardiac death, their likelihood of dying a sudden cardiac death was increased 9-fold. And in fact, if neither parent had a history of sudden cardiac death, but they had a past history of myocardial infarction, there was no increase risk of sudden cardiac death. There was an increase in fatal MI. So there are genetic predispositions that may be related to repolarization in the QT interval. But what bothers me, of course, is that the patient that I've seen with an out-of-hospital cardiac arrest due to MI, we may have taken care of the problem, but what about what's going to happen to them 5 years or 10 years down the line when they get another coronary artery occlusion? Are they going to fibrillate again? And so these are questions for which we don't have answers. But for the practically, the majority of our patients will end up with an ICD. So I want to close with this paper that did go to the New England Journal, even though it wasn't a randomized trial. Late long-term outcomes of out-of-hospital arrest after successful early defibrillation, published by our fellow Jared Bunch, and I was involved. And I really show this to pay tribute to this man, Roger White, who has made it his life's work to further the cause of CPR, just not only in Rochester, Minnesota, but nationally and internationally. And as a result of his work, the results in Minnesota are incredible. 200 patients with out-of-hospital cardiac arrest witnessed ventricular fibrillation, 1990 to 2000. 72 survived to hospital admission, 40% were neurologically intact at discharge. Now, I should add and mention that the coldest part of the United States, or one of the coldest, is Minnesota, where we live. So one criticism of this study was that we had an unfair advantage, and that is that all our patients were hypothermic at the time they were admitted to hospital because it happened outside. Thank you for your attention.
Thank you, Dr. Gersh. Any question or comment from the audience? I have a question. I think we have many tools to identify patients with ischemia, many tools to modify ischemia, revascularization, but we have not tools to modify substrate scar. In this time, in the time of ICD, what is the role of catheter ablation for patients with previous myocardial infarction who have ventricular tachyarrhythmias?
Yeah, it's a good question. It's an interesting philosophical point, and let me just repeat it. We have excellent tools for stratifying ischemia and getting rid of ischemia, but not for scar tissue. And I might add that all our methods of risk stratifying for sudden cardiac death basically have failed. Heart rate variability, barrier reflex sensitivity, all of this, none of it has worked. None of it has panned out at all. T-wave alternans has not worked. So the question is, in these people with residual scar tissue, if we were able to abolish the scar tissue, would we reduce the incidence of sudden cardiac death? Theoretically, yes. Practically, I think here's the problem. And in fact, Dr. Cook has done a trial of catheter ablation of VT in people with ICDs. And his postulate was, if I do a catheter ablation, then I put in the ICD, there will be less discharges. And there were. But it doesn't eliminate the discharges. And I think the problem is that the circuit can be micro re-entry. So you would have to get rid of like 100% of scar, not 99.5, because it just takes a few cells. So that approach is not there yet. What I do think is in the near future is the characterization in people who have an ICD, the MRI characterization of the scar border zone around a myocardial infarction. And what we'll be able to do, I think this is very feasible, is ablate those areas. They will still have an ICD, but we will spare them the shocks.
Thank you. More questions?
Thank you, Bernard. I have a question on a subset of patients that is not very frequent, but rather complex. And it is that of patients that present a sustained ventricular tachycardia in the first 48, 20, 72 hours after an acute myocardial infarction. These patients usually have a poor LV function and a worse prognosis, but do these patients need a specific approach in terms of further stratification, indications of
Thank you, Peter.
ICD and so on?
Yeah, this is a small, as you said, it's an uncommon group of people, but it's a problem, and that is the patient that presents with sustained monomorphic ventricular tachycardia in the first 72 hours after a myocardial infarction. They, to my mind, all have a substrate. They have scar. That's why they have sustained monomorphic VT. What I do with those patients, if it's a long, prolonged episode, 2, 3, 5 minutes of sustained monomorphic VT, and then settles down, I am studying those patients pre-discharge with programmed stimulation. Nearly all of them remain inducible. They will get an ICD. It's uncommon, though. It's very uncommon. We used to see it, but we don't see it in the reperfusion era much. So I think many of them are probably patients that may have had a prior infarct or some ischemic damage, and that's why. So I study all of them. I think it's a very serious finding, and they should be covered protected. Now, the study that I think I'd like to see done would be using the great national Scandinavian registries, maybe particularly Sweden, Denmark. And that would be to look at, I don't know if you can do it with some of the ICU registries here in Spain, but this is the study that needs to be done. Look at everybody that had an out-of-hospital cardiac arrest with a myocardial infarction. Some of them, I'm sure, had defibrillators when they left home. Some of them didn't. What happened to those patients? How many of those people that had an out-of-hospital cardiac arrest 6 hours before, they were brought in, or 1 hour before they were brought in, with an acute myocardial infarction, early event, we do put defibrillators in. Some of them we don't. We say it's due to acute MI. What has happened to those patients? How many of them have had subsequent discharges from their device? We just don't have enough numbers. We're trying to do the study, but if you have a large registry, I think it's critical data.
Thank you, Dr. Gersh, for your nice presentation, and we have to finish this session. Thank you to the presenters for the beautiful presentation and the audience for the attention. Thank you.